Good morning. We're broadcasting from Johnston, Iowa this morning. As you can see, it's bright and sunny. It's always bright and sunny in Johnston. It's beautiful. Chapter 15.4, Gynecological Surgery. As I said in class, we're kind of getting to the end of this chapter and we're getting into the meat of the chapter, the bulk of it. These are the bigger procedures that we're talking about. Total abdominal hysterectomy. This case, we're going to use your O&O, O'Sullivan and O'Connor, and a Balfour or a Balfour. We will be using maybe a Bookwalter retractor, some type of self-retaining retractor that gives us good access to the peritoneum. In this procedure, we're going to be clamping ligaments with our Haney clamps that we learned about in class and our Haney Ballantines. So, like the slide shows, it's clamp, clamp, cut, tie, and the tie is usually a stick tie or a tie on a pass, which is a tie either mounted onto a schnit or a peon or something that can let them push that tie down and around the Haney so they can tie off that ligament. When we're working in the belly like that, as the procedure progresses, you're going to be getting deeper and deeper towards that vaginal cuff, and we may need to use some extra long instruments. So things to have around would be that. Now that clamp, clamp, cut, tie procedure would be Haney clamp, cut with either a male scissors or Jorgensen scissors, and then the tie. And you'll repeat that process several times till you get through the ligaments. Vaginal hysterectomy, we're going to do things in the reverse order of the total abdominal hysterectomy. So we're going to start with the uterosacral ligaments, and it's still going to be Haney's, clamp, clamp, cut, tie. Only on these first few, we're going to, when they cut the tie, after he's done tying it, they're going to leave the tails long and tag them with a cryle or a Halstead mosquito, something. They're going to tag them because we're going to be reapproximating these ligaments. Cardinals will be after the uterosacrals, and we proceed on through. The uterine arteries, they might clamp with a schnit or a Kelly or a peon, something else other than a Haney. A Haney's a little too thick to clamp those smaller arteries. And like I said, the ligaments are approximated and reattached to the angle of the vagina. LAVH. LAVH is a procedure, as it shows, that is more expensive and has a longer operative period, but the patient has a very quick recovery, can be back to work or other activities very quickly. When passing medications, this is important, and I've said this in class, so has Betty. When passing medications, state the medication to the surgeon. And if there's additives to your medication, such as epinephrine, tell them with epinephrine. They need to know that there are toxic limits to certain medications that you want to give to somebody. You can have very adverse reaction if you go past those toxic limits. Robotic assisted. Thing to remember about some of these minimally invasive procedures is they can always convert into an open procedure. So we want to be cautious of that and make sure we have open instruments available. Radiation seeding. This is for uterine cancer, and many different techniques to do this. One thing that's important to realize is that they're going to guide those needles with ultrasound. They're going to use an ultrasound image live and watch as they push that needle through, and when the needle comes out, the seeds are in. Done. Vertimes, radical hysterectomy. This is going to be supine, laparotomy. We're going to have probably several pathology specimens. This is for extensive tumor, like the slide shows. This is kind of a big procedure. Going to take a little while. You're going to get one big specimen. En bloc means you're getting one big specimen. Pelvic exoneration, we've talked about in class also. It's kind of like the radical hysterectomy, jacked up. It's even more. We're going to go after part of the sigmoid colon. We're going to take the bladder and the ureters. You get a lot of stuff out of this. Important to know is that the ileostomy comes out the right side of the abdomen. The colostomy comes out of the left side of the abdomen. And big long case, this one can kind of wear you out. Also to note about that case is that we're gonna put a J tube in for decompression, a jejunostomy tube, and we're gonna put a G tube in, which is a gastrostomy tube, for nutrition. So a lot of things to do in a pelvic exoneration. Got stomas to create, big huge specimen coming out, lymph nodes. It takes a long time to get through one of these. This is an all-day deal. Anterior and posterior repair, we talked about these in class for a month. And just tenting that vagina back together so that it has a nice canal again. When the bladder prolapses into the vagina, oftentimes there's a degree of incontinence. So you're going to have a hard time controlling the wetness down there. So these, when they clamp the vaginal mucosa back together to sew it, they're going to want Alice clamps. And you may need more Alice clamps than what you have. So just keep that in the back of your mind when you're doing these vaginal vault repairs. You're definitely going to need more Alices. Also, the sutures that we use for vaginal mucosa are always absorbable. Now, sometimes they're a braided absorbable, sometimes they're a monofilament absorbable, and that kind of surgeon preference, but they are all absorbable sutures. We want those to dissolve. That kind of wraps up chapter 15. Next week we start into orthopedics, so have a good weekend and study hard. Thank you.